For all things health and fitness, this is the Army Gymnastics Podcast.
The Army Gymnastics Podcast.
Discover a fitter, healthier you at armygymnastics.com.
Welcome back to the Deep Dive. We're really glad you could join us, and especially grateful you brought us this fascinating stack of sources to get into today.
It's great to be here.
Today, we're tackling a topic that's just incredibly important. It touches so many lives directly and, indirectly too.
Absolutely.
This deep dive is all about prostate cancer, a smarter way to fight back, and we're really letting the material you shared guide the conversation.
And navigating the sheer amount of information around a major health challenge like prostate cancer, well, that's exactly what we aim to do here. Your sources make it clear right from the get-go. This is the most significant major malignancy for men.
Yeah.
It carries a heavy burden, not just in terms of mortality, sadly, but also how the disease and its treatment impact daily life.
It's a reality for so many men and their families, and there's been amazing progress in treatment, hasn't there?
Oh, definitely.
Like therapies like androgen deprivation therapy, ADT, your sources mention it's helped push the 5-year survival rate way up, maybe even to 92%, according to one source, which is fantastic news.
It is fantastic news for survival, but, and this is a really big but that comes through strongly in your sources, that's not the whole story.
Right.
That's where the challenge really comes in. ADT, while it's powerful for controlling the cancer itself, it often comes with these really profound adverse effects. Side effects that can seriously reduce a man's quality of life.
Even while the treatment is working to save his life.
Exactly. It's a difficult trade-off.
And the material you provided points to some significant physiological changes from ADT, right? Things like increased risk for metabolic problems, cardiovascular issues.
There's changes in body composition, too, like gaining fat, losing muscle mass, which isn't ideal, and just a general reduction in functional capacity, physical ability.
But the sources seem to really zero in on one side effect in particular as maybe the most common and, distressing one.
That's right. Cancer-related fatigue, or CRF. They state that up to, 74% of men treated with ADT experience this. 3/4 almost.
And we need to be clear about what CRF is based on the descriptions. It's not just, feeling tired after a busy week.
Not at all. The sources describe it as this distressing, persistent sense of tiredness. It feels completely out of proportion to whatever activity you've done, and it actively gets in the way of normal functioning, day-to-day life.
That sounds incredibly tough.
And what makes it particularly challenging is the timing. It can come on relatively quickly, maybe as early as 12 weeks into ADT, and it can stick around for a long time. We're talking potentially over a year after treatment finishes for some men.
Wow.
So managing CRF isn't just some minor comfort measure. Your sources really underscore that it's absolutely critical for maintaining quality of life, both during the treatment journey and, into survivorship afterwards.
Okay. So our mission today, diving into these sources you've given us, is to really understand the key stats, the risk factors, grapple with these big treatment challenges like CRF.
And then explore some of the promising research you highlighted, particularly looking at non-pharmacological approaches, things like nutrition and exercise, that might help lessen these side effects.
Exactly. We want to pull out the actionable insights, see what the sources suggest about fighting back in a smarter, more holistic way.
Sounds like a plan. Where should we start? Maybe with the big picture. Prevalence, risk factors.
Yeah, let's ground ourselves there first. How common is prostate cancer and who's most at risk, according to this material?
Well, stepping back, the sources confirm it's a major global health issue for men. Its impact is really widespread.
Okay.
And when we drill down into the risk factors detailed in the material, ethnicity really jumps out. There are some quite significant disparities mentioned.
This was one of the most striking things in the sources, I thought. It points out that non-Hispanic Black men or African-American men in the U.S., they face the highest rates of getting prostate cancer and the highest rates of dying from it, not just in the U.S., but globally.
The numbers are quite sobering, really. They speak volumes about health disparities. Your sources say African-American men are about 1.7 times more likely to be diagnosed compared to white men.
1.7 times more likely. And the outcome difference is even starker, isn't it?
It is. More than twice as likely to die from the disease. One source gives specific figures that really drive it home. Something like 37.2 deaths per 100,000 African-American men versus about 18.1 per 100,000 for white men.
That is a huge gap.
Huge. And looking at lifetime risk, the material indicates about 1 in 6 Black men in the U.S. will get a diagnosis in their lifetime, For white men, it's about 1 in 8.
Still significant for white men, that 1 in 8. But the difference is clear. Do the sources suggest why this disparity exists?
They touch on potential contributors, things like known genetic differences that might relate to how prostate cancer progresses in men of African descent. It's complex, obviously, but genetics seem to play a role.
Okay. And it's important, as you said, that 1 in 8 risk for white men is still substantial. It affects a large number of people.
Absolutely. And the sources also show different patterns for other groups. Hispanic or Latino men, for instance, tend to have lower rates than non-Hispanic white men.
And Asian and Pacific Islander men.
Generally, the lowest incidence and mortality rates among the major racial and ethnic groups discussed in the U.S. context in these sources. So, yeah, while the why is complex and research is ongoing, the data presented makes it very clear. Ethnicity, particularly being of African descent, is a major risk factor highlighted here.
Okay, so ethnicity is a big one. What else do the sources point to? Genetics more broadly, family history.
Yes, definitely. Genetics and heredity play a crucial role. Simply having a family history of prostate cancer significantly bumps up a man's personal risk.
And the sources actually make a distinction there, don't they, between different types of family links?
They do. They talk about hereditary prostate cancer that accounts for maybe 5 to 10% of cases. This is where there's a clear identifiable genetic inheritance pattern driving the risk, like specific gene mutations passed down.
Okay, 5–10%. And the other type?
It's called familial prostate cancer. This is more common, accounting for maybe 15 to 20% of cases. Here, you see prostate cancer cropping up in families more often than you'd just expect by chance.
So maybe a mix of genes and other factors shared by the family.
That's the suggestion, yeah. It could be a combination of genetic predispositions that aren't as strongly deterministic as in the hereditary form, maybe combined with shared environmental factors or lifestyle habits, though the sources don't really dig deep into those specific family dynamics.
Got it. So strong links to ethnicity and family genetics. What about lifestyle? Do the sources get into things like diet and exercise?
They do touch on it, yeah, drawing some points from, I think, is a Wikipedia source included in the material, but the language used is often quite cautious. You see phrases like may reduce or may increase.
Okay. So less definitive than the ethnicity or genetic data.
Exactly. It suggests there's research out there, potential links, but maybe not the same level of consistent, conclusive evidence, or at least not presented as such in these specific sources.
Makes sense. What kind of potential links did it mention? Exercise.
Yeah, it mentions that regular, vigorous exercise may potentially lower the odds of developing advanced prostate cancer, which kind of aligns with general health advice, but specifically targets the more aggressive forms here.
Okay. And diet.
Diet gets a bit more discussion, again, with that cautious may. A diet rich in things like cruciferous vegetables, broccoli, cauliflower, leafy greens, plus fish, genistein from soy, lycopene from tomatoes. That pattern may be linked to a lower risk of symptomatic prostate cancer.
Interesting. And on the flip side, things that might increase risk.
The source suggests high intakes of dietary fats, or these things called polycyclic aromatic hydrocarbons, which you get from cooking red meats at high temps, especially charring.
Ah, the barbecue effect.
Kinda, yeah. Also
Sure.
potentially high calcium intake. These may possibly increase the risk of advanced prostate cancer, according to that source.
It's also interesting what the source said didn't seem to affect risk, right?
Yeah, that caught my eye too. Certain supplements that people often think about for cancer prevention, selenium, vitamin C, D, E. This source mentioned studies finding they did not impact prostate cancer risk.
So the takeaway seems to be that while lifestyle factors are mentioned as possibilities, the emphasis in the material you provided really seems to land more heavily on those undeniable statistical connections with ethnicity and family history.
That seems fair, based on this selection of sources, yes. The evidence presented for ethnicity and genetics appears stronger, or at least more consistently emphasized.
Okay, so we've kind of laid out the risk landscape based on your sources. Now let's pivot. Let's get deeper into the challenges men face after they're diagnosed, especially during treatment.
Right, and this brings us straight back to treatments like ADT and their impact.
We touched on it earlier. These treatments are incredibly effective for controlling the disease, improving survival stats dramatically.
Absolutely, but they don't come free. There's a significant cost in terms of physiological changes and, importantly, quality of life.
Yeah, the sources really hammer this home. ADT imposes a heavy burden because it messes with the body's hormonal balance.
Exactly, leading to those things we mentioned. Higher risk of metabolic syndrome, heart problems, the shift in body composition, More fat, less muscle.
Which affects strength and function.
Definitely.
Yeah.
And just a general decline in physical capacity overall.
And then there's the big one again, the one highlighted most prominently in the material affecting, what, up to 3/4 of men on ADT.
Cancer-related fatigue, CRF.
Yeah. And it's worth just sitting with what that means for a moment. Imagine, this profound, persistent exhaustion. It doesn't get better with a good night's sleep.
Right.
Simple daily tasks suddenly feel like climbing a mountain. It fundamentally changes your ability to engage with life, work, hobbies, relationships, everything.
The sources make it absolutely clear this isn't just feeling a bit wiped out, it's often debilitating,
Yeah.
affecting up to 74% of men on ADT.
And the timeline, again, coming on fairly quickly, potentially lasting for ages.
Months, even over a year post-treatment for
Yeah.
some, it really impacts daily functioning and emotional well-being in a big way.
So when we talk about fighting back against prostate cancer, using that phrase from our topic title, it's clearly not just about killing cancer cells.
No, it's fundamentally also about managing the physical and emotional toll of the treatment itself. Improving quality of life during therapy and after therapy has to be a central part of comprehensive care.
Which leads us neatly into a really, I think, hopeful and forward-looking section of the sources you shared, the part detailing a specific study protocol.
Yes, the research plan looking into ways to manage these side effects, focusing specifically on non-drug interventions.
Exactly. This particular source lays out a protocol for a study exploring how nutrition and exercise interventions might help mitigate that cancer-related fatigue in men who are on ADT.
And the why behind this research, as the source explains it, is really compelling. While there are some existing ways to manage CRF, often involving medications,
Right.
there's this growing body of preliminary evidence suggesting that natural therapies, especially targeted diet and exercise, could actually play a significant role in easing these symptoms.
But there's a gap, right?
Right.
That's what the source says this study aims to address.
Precisely.
Yeah.
It identifies a key limitation. There aren't really specific, tailored dietary guidelines out there for men with prostate cancer focused on managing treatment side effects like fatigue. General healthy eating advice, sure, but not tailored guidance.
On the exercise part.
Similar gap. High-intensity exercise, specifically, hasn't been widely studied in this particular group, men on ADT dealing with these specific side effects. So this study was designed to try and fill those knowledge gaps, provide more concrete evidence.
Okay, let's unpack the design of this planned research then, as it's laid out in the source. What kind of study was it?
It was set up as a two-arm randomized controlled trial, or RCT, which is, a gold standard design in medical research.
Right, participants get randomly assigned to different groups.
Exactly. That helps ensure that any differences you see at the end are likely due to the intervention being tested, not just chance or other factors. And this trial was planned to run for 20 weeks.
And who are they planning to recruit?
A specific group, 116 men. They either had prostate cancer or were survivors, and they had to be currently receiving ADT and had been on it for at least 3 months prior to joining the study.
Were there other criteria for who could be in it?
Oh yeah, the source is quite detailed on the inclusion and exclusion criteria. Participants had to be adults, 18 or over, non-smokers, or have quit at least 3 months before, and their BMI needed to fall within a certain range, 18.5 to 34.9.
Okay, and who couldn't participate?
They excluded men taking certain supplements beyond a basic multivitamin, unless prescribed. Also men with health conditions that would make exercise unsafe for them. Importantly, men with bone metastases were excluded. High-impact exercise could be risky there.
Excellent.
And also, men who are already doing regular high-intensity exercise couldn't join. They wanted to see the effect of introducing it. And a key point, participants needed the guidance and consent from their own urologist. Safety first.
Absolutely. So once they had these 116 men, what happened? They were split into two groups.
Right. Randomly assigned. The first group was the intervention group. They were scheduled to get two main things.
Okay.
First, individualized nutrition therapy for the whole 20 weeks. And second, starting a bit later, from week 12 through to week 20, they'd also add in high-intensity interval training, HIIT.
Got it. Nutrition for 20 weeks, HIIT added for the last 8 weeks. And the other group?
That was the usual care group. They just continued with their standard medical treatment for their prostate cancer, including the ADT for the full 20 weeks. They didn't get the specific structured nutrition or exercise interventions being tested in the study. They served as the comparison.
And how are they going to track if the interventions made a difference?
The plan involved collecting a lot of data at several time points. At the very beginning, the baseline assessment. then again at week 8, then week 12, which was right before the HIIT part started for the intervention group, and then a final assessment at the end, week 20.
So they could see changes over time and compare the groups at each point.
Exactly. That allows the researchers to really track the trajectory of change.
Let's dig into those interventions a bit more. The nutrition therapy, what did that actually involve? It wasn't just eat healthy, right?
No, it was much more structured and personalized than that,
Yeah.
based on the protocol description. It was delivered by an accredited practicing dietitian, so a qualified professional,
Okay.
and it was designed to be individualized. They planned to start by getting detailed diet histories from each participant, and then check in regularly, like every 2 weeks, using things like 24-hour dietary recalls to see what the men were actually eating.
So ongoing monitoring and adjustment.
Yeah. The source says it wasn't strictly prescriptive, like handing out a rigid meal plan. Instead, it focused on setting food-based goals that were tailored to each man's starting point, their current body composition, their current diet quality compared to general guidelines, like the Australian dietary guidelines mentioned in the source.
Did it involve calorie targets?
It seems so, at least initially for some. It mentions that if a participant's baseline diet or body composition suggested it was needed, the dietitian would emphasize reducing total energy intake. The goal mentioned was a reduction of around 2,000 to 4,000 kilojoules per day. That's roughly 500 to 1,000 calories.
So potential weight management was part of it for some?
It looks like it, alongside improving the overall quality of the diet. The general pattern they encouraged was described as a modified Mediterranean-style diet.
Okay, what does that mean in practice? What kind of foods?
The focus was on gradually increasing plant-based foods over the 20 weeks. The protocol gives examples of the types of recommendations. Things like encouraging whole grains aiming for 4 to 6 serves a day, like multigrain bread or oats.
And fruits and veggies.
Loads of them. A target of 2 serves of fruit and 5 serves of vegetables per day. They gave examples like apples, bananas, tomatoes, carrots, green beans, even frozen mixed veg counted towards the goal.
Good to know. What else?
Boosting fiber intake was key, mainly from those grains, fruits, and veggies.
Right.
But also a specific goal mentioned was eating lentils or beans regularly, about a cup a day.
Okay, plant-based focus. What about protein?
Lean meats were recommended a few times a week, with specific portion size guidance for beef, chicken, eggs, etc. But they also specifically advised reducing or even eliminating meats that might be carcinogenic, mentioning charred red meat and processed meats like salami or sausage.
So less processed and charred meat, more lean options.
Fish. Oily fish like salmon or tuna, known for healthy fats, were recommended 2-3 times per week.
Dairy. Nuts and seeds.
Yep, dairy was included, suggesting 2-3 serves of reduced fat options like milk or soy milk daily. And nuts and seeds were encouraged daily, about 30 grams, like a handful of almonds or walnuts.
And what about things to limit or avoid?
The plan involved cutting back or eliminating discretionary foods, things high in added sugar, unhealthy fats like biscuits, sweets, soft drinks, fatty takeaways, and limiting alcohol to very moderate levels, 0 to standard drinks, or eliminating it.
That sounds pretty comprehensive. How did they help the participants actually make these changes?
They plan to use supportive educational materials like pamphlets and also techniques like motivational interviewing. That's a counseling approach to help people find their own reasons and motivation to change their behavior. The goal was this gradual, supported shift over the 20 weeks.
Okay, so that's the detailed nutrition piece. What about the exercise, the HI2 component that started at week 12?
Right, the high-intensity interval training. This was planned for 3 sessions per week.
How long were the sessions?
Each session was structured to be about 38 minutes total, and it was done on a cycle ergometer, basically a stationary bike that allows for precise control and measurement.
And what did a HIT session look like? Was it just pedaling hard the whole time?
No, that's the interval part. It involved periods of really high effort mixed with periods of recovery. The source describes a typical session structure, a 10-minute warm-up at a moderate intensity.
Okay.
Then, the core part, 4 bouts of cycling, each lasting 4 minutes, at a very high intensity, aiming for 85–95% of the person's peak heart rate, really pushing it.
4 minutes sounds like a long time at that intensity.
It is challenging, yeah. But between each of those intense 4-minute bouts, there's a 3-minute period of active recovery still pedaling, but at a much lower intensity, like 50–70% of peak heart rate, to catch their breath before the next high-intensity interval.
Got it. Warm-up, then 4 rounds of high-intensity active recovery. How did they ensure safety?
They plan to monitor heart rate and blood pressure throughout the sessions. Safety was clearly a priority.
It definitely sounds like both the nutrition and the exercise interventions were very structured, well-planned, and tailored where needed.
Absolutely. designed to be delivered consistently and safely within the research context.
So they had the two groups, the interventions. How were they actually going to measure if it all worked? What were the outcomes they were looking for?
The source lists a whole range of outcome measures they plan to collect. They had primary outcomes, the main things they really hoped to influence.
Which were?
Fatigue and overall quality of life. Those were the big targets.
How did they measure fatigue?
They plan to use a specific validated questionnaire called the AFFIC-TF. It's designed precisely to measure cancer-related fatigue. It gives a score, and basically a higher score means less fatigue. It's a standard tool in cancer research.
And quality of life.
Measured using questionnaires, too. They plan to use a general health survey that's widely used, plus specific questionnaires developed by the European Organization for Research and Treatment of Cancer, the EORTC ones. These are tailored to capture quality of life issues specific to cancer patients, including things relevant to prostate cancer and its treatment side effects.
Okay, so fatigue and quality of life were the main goals. Were there other things they measured, secondary outcomes?
Yes, quite a few secondary outcomes to get a more complete picture. They plan to measure physical characteristics, height, weight, waist circumference, and also use DXA scans.
Ah, for body composition.
Exactly. To get really precise data on how much lean muscle mass versus body fat participants had and whether the interventions changed that.
What about fitness levels?
Yep. They plan to assess exercise capacity and cardiorespiratory fitness. This included simple timed walk tests, like how fast can you walk 400 meters, but also a formal VCHO2 peak test on the cycle ergometer.
That's the one that measures your maximum oxygen uptake.
That's the one. It's a key indicator of cardiovascular fitness. The protocol included details on how they do this safely, gradually increasing the bite's resistance, monitoring heart rate, blood pressure, and how hard the participant felt they were working using an RPE scale.
Okay. Fitness, body composition, anything else? Blood tests.
Yes, blood samples were planned for collection at the different time points. They intended to analyze standard things like cholesterol and triglycerides,
Yeah.
but also more specific markers that might be relevant.
Like what?
Things like PSA, the prostate-specific antigen, also markers related to growth factors like IGF-1, markers of inflammation like IL-6 and IL-8, and even a marker related to iron metabolism called hepcidin. The idea was to see if the interventions influenced these biological pathways.
Wow, quite detailed. Did they also track if people were actually following the diet?
Yes, dietary intake wasn't just the intervention, it was also measured throughout, using dietary questionnaires and those regular 24-hour recalls with the dietitian to check adherence and see how eating patterns changed overall.
And any psychological measures? Mood, sleep?
Yep. They plan to use standard questionnaires to assess symptoms of depression, anxiety, and stress using the DAS scale. Also the Insomnia Severity Index, ISI, to check sleep quality, and even a scale to see how much participants enjoyed the physical activity, the PACES questionnaire.
One last thing, did they just rely on people saying how active they were?
No, they planned for an objective measure too. Participants were asked to wear an accelerometer, one of those little devices that tracks movement, like a fancy pedometer for a full week at the different assessment points, to get a real sense of their overall activity levels outside the specific HIIT sessions.
Okay, that is a very comprehensive list of outcome measures.
Yeah.
It really shows they planned to look at the potential impact from many different angles.
Absolutely. Beyond just fatigue and quality of life, they wanted to see effects on fitness, body composition, various blood markers, psychological well-being, actual activity levels. A really thorough investigation was planned.
So this protocol, this plan for a study,
Yeah.
why is it considered important? What's the significance, according to the sources?
Well, the sources circle back to the core problem.
Yeah.
That cancer-related fatigue is a really major issue for men on ADT. It's distressing, it can last a long time, and managing it effectively is just critical for quality of life during and after treatment. And while there's promise from earlier, maybe smaller studies, that nutrition and exercise could help with CRF and other ADT side effects, this particular trial, as described in the protocol, is highlighted as being potentially the first of its kind.
First in what way?
The first to really investigate the impact of this kind of structured, individualized nutrition therapy, going beyond just general healthy eating advice, specifically for managing prostate CRF.
Ah, addressing that gap in specific dietary guidelines we talked about.
Exactly. The sources point out that lack of tailored dietary guidance is a real limitation right now. So research like this could offer really novel insights into whether these targeted nutritional strategies actually make a difference.
And the HIIT component.
Similarly, while exercise is generally good, specifically investigating high-intensity interval training for reducing CRF and improving quality of life in this specific population. Men on ADT is noted as something that really expands the existing exercise oncology literature. It's asking, is this efficient, potentially powerful form of exercise safe and effective for these men?
So the authors of the protocol see it as pretty significant.
They describe it as a landmark study. Their aim was to provide novel, specific evidence that could actually help support the development of desperately needed clinical guidelines for managing CRF and those other tough side effects of ADT.
And the underlying hope, the hypothesis,
Is a positive one, that the individualized nutrition therapy on its own would help, and that combining it with HIIT would lead to even greater improvements in CRF and the other adverse effects men face on ADT. While we're just looking at the plan here, not the results, the intent is clear. Find better ways to help men live well, even while undergoing necessary life-saving treatment.
that's a really important goal. Now, stepping back a little, the sources you provided also touched on a broader context, didn't they? Something about cancer care within the larger healthcare system and costs.
Yes, that came up. There was some discussion around that.
One source presented some survival statistics comparing the U.S. to other developed countries, the OECD average. It showed the U.S. actually has pretty high 5-year survival rates for some major cancers.
Right. Like for prostate cancer, it mentioned around 97% survival in the U.S. versus maybe 87% OECD average. Breast cancer was about 90% versus 85%. Colorectal, 64% versus 60%. So for those who get treated, the outcomes measured by 5-year survival look relatively good in the U.S. for these cancers.
But that positive picture was kind of contrasted in other parts of the material, particularly that Reddit thread source, right? Which talked a lot about costs.
Exactly. That discussion really highlighted the perception and often the reality of the U.S. healthcare system being significantly more expensive than systems in other comparable developed nations.
Did that source offer reasons why it might be so expensive? Keeping in mind these are viewpoints from a discussion forum.
It did. It mentioned several potential factors that people were discussing, things like high administrative costs, possibly linked to the complexity of having multiple insurance payers instead of a single system, the high price of prescription drugs in the U.S. compared to elsewhere, a lack of price transparency. It's often hard to know what things cost beforehand.
Any other points raised?
There was mention of the potential influence of various lobbies, pharmaceutical companies, insurance companies, maybe even some medical professional groups with suggestions about controlling supply or pricing.
Okay, so a range of viewpoints on potential cost drivers. It's important, as you said, to present these impartially as points raised in that source discussion, not necessarily proven facts laid out across all the material.
Absolutely. It reflects an ongoing debate and public concern about healthcare costs.
And that same discussion forum source also brought up a nuance, didn't it? About survival rates versus overall health.
Yes, it made the point that while survival rates for specific diseases like cancer might be high, particularly for those with good insurance coverage, overall, U.S. life expectancy longevity is actually lower than in some other developed countries that spend less on healthcare.
Which definitely complicates the picture. It suggests that just looking at disease-specific survival might not tell the whole story about population health or the overall value being delivered by the healthcare system.
It's a complex equation, for sure.
So how does this broader context maybe tie back to the research study we spent time on, the nutrition and exercise one?
Well, you could see initiatives like that, study research, looking into non-pharmacological, lifestyle-based interventions as potentially being part of a bigger picture. An approach to improving not just survival, but also the quality of that survival, the lived experience during and after treatment.
Right, managing the long-term effects.
Exactly. And by focusing on managing side effects through lifestyle changes, interventions like targeted nutrition and exercise could, maybe, potentially play a role in managing long-term care needs and perhaps the associated costs down the line.
While the study protocol itself didn't get into healthcare economics.
No, it didn't. But the type of research it represents, trying to find effective, non-drug ways to improve patient well-being and function, could have implications for those broader discussions about value, effectiveness, and the cost of long-term cancer survivorship care. It sits alongside the traditional medical treatments.
It highlights how research focused on the patient experience and supportive care fits into that larger, complex landscape of cancer care and healthcare systems that your sources brought into the discussion.
Well put.
Okay, wow. We have really covered a lot of ground in this deep dive, thanks to the sources you brought us. We started by looking at the landscape of prostate cancer itself, how common it is, the crucial risk factors, especially those significant disparities linked to ethnicity, and the role of genetics and family history.
Then we shifted into the tough realities of treatment. We focused on the significant side effects of therapies like ADT, really honing in on cancer-related fatigue, CRF, as this major, often debilitating issue that impacts the vast majority of men going through it, seriously affecting their quality of life.
And importantly, we then explored that detailed research protocol described in your sources. A plan for a rigorous study investigating whether structured, individualized nutrition therapy combined with high-intensity interval training could actually be an effective non-drug strategy to help manage CRF and potentially other ADT side effects.
And we noted why that planned research is significant, aiming to provide specific, needed evidence. Evidence that could potentially inform clinical guidelines, addressing current gaps in tailored dietary advice and research on HIIT for this specific group of men.
It really does underscore the importance of looking at the whole picture, doesn't it? Beyond just the tumor, to the holistic experience of the person going through treatment and survivorship. Ongoing research into evidence-based lifestyle interventions seems so crucial.
Absolutely. It's about complementing the essential medical treatments with strategies to help men truly fight back against the full impact of the disease and its necessary therapies, improving how they live through it and after it.
Which leaves us with a final thought for you, our listener, to mull over. Something building directly on all this material we've unpacked today.
Considering the profound, often long-lasting impact of treatment side effects like fatigue on daily life, and considering the potential benefits that research into lifestyle interventions like tailored nutrition and exercise suggests, how might the further integration of these kinds of evidence-based approaches genuinely reshape the standard of care for men with prostate cancer in the future?
Could we move towards a model that more explicitly prioritizes living well alongside living longer?
A powerful question indeed.
Something to think about. Thank you so much for providing the source material that made this deep dive possible today. We really appreciate you being with us.
Thanks for listening. For all things health and fitness, subscribe to our newsletter today. Find out more at armygymnastics.com.